to this 76th edition of our webinars being organized by the Andhra Medical College on COVID-19. And you are all aware that we had a lot of discussions about the treatment, and we had a lot of discussions about how to prevent as well as how to diagnose. So we have covered a variety of subjects so far, and we had 31 daily episodes also moderated by Dr. Kairam. And now, over a period of time, we have learned to discuss what is more important under the situation. So now, in the present scenario, it is the third wave which is being talked about very extensively, and also the variants and the vaccine escape, why people are getting infected though they have taken vaccine, and also the post-COVID sequelae. These are the important issues that need to be talked about now. And as you're all aware, that Dr. Sridhar Chirumuri has been imparting this knowledge right from the beginning, whenever we needed his help. Even with a short notice, he has been coming on board and telling us as to the way forward. And I mean, over a period of time, I realized that he's the one who has to be relied upon when we want to have a speaker, and particularly when we have some serious problems like the vaccine escape and issues like third wave. Because the third wave is talked about very extensively. People are talking without possible scientific background. So I felt that it is better if we listen to him before anybody can conclude. And I'm very glad that he needs no introduction to this audience, Dr. Sridhar Chirumuri, because he is the one who has been handling the entire CME along with Dr. Kairam for the last almost 1 year. And I'm very glad that he has agreed again to speak on the determinants of third wave. Can we prevent it? And I'm very thankful to Dr. Kairam and Dr. Sridhar for taking this forward. And in the days to come, we have very good speakers coming up on speaking on the issues that are of interest in the current scenario. So thank you very much, Sridhar, and please proceed.
Okay, thank you. And actually, you guys there in India are doing all the work. All we do now is speaking here. That's about it. But thank you for asking me to come back. Making predictions of the future when it involves viruses, human beings, and politics is a hazardous profession to be in. But I'll attempt to kind of throw light on what is happening with the virus and the vaccines, and what can we expect in the coming several months. So what determines the persistence of a pandemic? Obviously, three main things. One is viral characteristics as the virus variants develop, so that would be one. The second one would be the host susceptibility, which is, I use the word host because it's not just humans that we should be concerned about. The virus actually does infect animals, so I'll briefly speak about it. And then the population dynamics of lockdowns, masks, and briefly, I'll cover that topic too. So why do viruses develop variants? I mean, this is universal. It's not just this virus. Other viruses do behave the same way. One is viruses which are replicating at a high rate will have intrinsic error rates, which may create mutations. Several of them may be fatal for the virus itself, and they get eliminated. Surprisingly, the COVID virus, despite of millions of replications that are happening each day, doesn't have that a very high error rate. So it doesn't really develop enough mutations for it to become obsolete or become more dangerous that easily. The second characteristic of a virus is as variants are developing, does the virus actually lose its functionality or its fitness for survival, or does it gain its ability to survive. So that would be another reason why, and I'll discuss this a little bit more. And the immune selective pressure that the virus is on, based on antibodies that we may be giving patients, like monoclonal antibodies, or immunity that's developing in the society after so many infections, that will put pressure on the virus to either mutate or become obsolete. Right now, we don't see a huge amount of pressure on the virus to mutate constantly. There is some of that pressure, and so certainly it is mutating. And the question of herd immunity, which truth be told, in most deadly viral infections, herd immunity almost always happened when we gave vaccine, like polio and measles. Assuming that infections alone will give us herd immunity is a myth. It's unlikely to happen. And then the characteristics of the virus going into other species and ping-ponging back and forth between animals and humans and back and forth, just like the influenza virus does. And then the size of the pandemic and the number of variants that it would generate. One is if you have millions of people every day getting infected, which is what is happening now, and in each individual, there are millions of replication cycles that are going on, you can expect a certain number of variants, and which is no surprise, we're seeing what we can. And the only way we would reduce that is to actually reduce the size of the pandemic, and we'll come to that. And then the plasticity of the antigenic site since we depend on the spike antigen more than anything else with this virus, is that antigenic site conserved, or is it variable? And that's something that I also want to cover. And then the selective pressure that's caused by vaccinations, producing antibodies, and convalescent plasma, will that generate mutants? And monoclonal antibodies. And we are concerned that they could, if inappropriately used. So let's go to this particular, the immune dominance of this virus. So we know that the virus totally depends on the spike protein, which is what's illustrated here. It's a trimer, which has, in some phases, it'll be a closed portion of the virus. And in other, when it gets into human beings, there will be an open domain of the S protein. And so what's become clearer over the last several months is that the virus has one portion of its spike protein, which is shown here, which actually sticks out. And this portion of the protein sticks out, especially when after it gets into the human host. And this portion of the spike protein is highly immunogenic. And so when a person gets infected with the COVID-2 virus, humans react to it quite well, produce large amount of antibodies. And in fact, the more severe the infection, more the antibodies that are formed. And so this seemed to be a nice place for us to have, that the virus has a single area which jets out and produces antigenic sites for us to react, and we produce antibodies appropriately. Unfortunately, this is also the part of the spike protein which mutates the most. So we are producing, the virus produces an antigenic site which protrudes out, is easily recognized by the human immune system, produces large amount of antibodies, but that's the portion that mutates out the most. So it is behaving exactly like influenza virus. So influenza virus, every year when you get an infection, one portion of the protein, the hemagglutinin portion, sticks out, and we react to it very well and produce potent antibodies against it. And that is the reason why you rarely ever get a flu twice in a year. There will be here and there some cases, but by and large, once you get infected with flu virus this year and get disease from it, you produce enough antibodies that you rarely will ever get a second infection. But what happens is that next year when it comes back again, you do have all the antibodies that you need against the flu virus, but for the strain that came last year. So the new strain that came now would have completely mutated out, and so your antibodies that you have are no longer effective. So the COVID virus is doing almost similar to exactly that. The spike protein, again, the portion of the spike protein that we're reacting against is the one that's mutating the most. And so we know now even more information. This is from patients in Switzerland, where they took all the 400 patients or so who recovered from COVID and took their serum. And this is high level of resolution antibodies, isolation of antibodies of different kinds that the convalescent serum had, and then measured them to see which portion of the spike protein do they go and attach themselves. And so this panel will show hospitalized patients, meaning these are moderate to severe patients. And then there are symptomatic patients, meaning they may have mild to moderate disease at best. And then the asymptomatic patients who were probably found to have during routine screening, or and that's about how they found out these patients to have COVID infection. And if you notice that those who are severely ill produce lots of antibodies, and people who are mildly symptomatic produce fewer antibodies, at least the asymptomatic individuals produce fewer antibodies. Now there are different type of antibodies that you produce, and these are shown in different colors. And these two particular antibodies, as you can see, SH1 and H13, are produced in large amounts, and they attach to portions of the virus over there. And this is the portion you're producing all the antibodies against. And if I showed you in the previous panel, this is the part that mutates the most. So the part that doesn't mutate that much, we just have this particular S309, not producing a lot of antibodies, even in the severely ill, but this is of importance for us as we go forward, as I explain in the next few slides. So the S309 is actually attaching itself in a different portion of the antibody and is not the portion that mutates the most. And this is important for us to have. So this particular antibody may be the antibody of the future, which might be resistant to any variations. So it's important to keep an eye on that one. And so what we are faced with is a virus that's constantly mutating in the spike protein process. And so I want you to focus on this particular structure here, where we are comparing two different viruses, the COVID-2 and the SARS-CoV, the original one. The original one is in the light colored blue here, which is a very small portion of the spike protein that actually mutates that. The variants are. Now, once it comes to SARS-CoV-2, the variations are quite significant. Many portions of the spike protein are showing these variants already. But there is always this conserved portion in dark blue that doesn't mutate that much. And this particular portion is similar in other species too, like MERS, MERS virus. Also, this portion is stable, doesn't mutate that much. So what we are faced with is a portion of the virus that's mutating quite a bit, and a portion of the virus which is quite conserved and not mutating that much. And we need to have that because as we go forward, we may have to develop antibodies to the conserved portion of it. So even if the virus mutates, you will have effective antibodies. Right now, so this concern has become a reality. So how do we know that the virus is becoming resistant? You harness antibodies and then grow them in the lab, which is monoclonal antibodies, and then later on check them to see if they're neutralizing the various types of variants that are there. And unfortunately, immune escape has already been demonstrated both clinically as well as in the laboratory. These are all the variants of COVID currently, including the Delta virus here. And these are all the variations of the spike protein that you're seeing. And these are in this panel, The green will show you that it's still susceptible, meaning you can neutralize it using this monoclonal antibody. And the red dots will show that it's totally, it is no longer able to neutralize the virus anymore. The neutralization studies are done primarily in vitro, although we now have some clinical evidence that certain monoclonal antibodies don't work. So if you look at this, currently you have 3 different monoclonal antibodies available in clinical practice. The first one is the Regeneron one, the second one is the bamlanimab, and the new one, this is the sotorvimab, which just got released. And this is unusual monoclonal antibody. And this is actually the antibody that I talked about, goes after the site S309. And this particular antibody is different than the other ones in the sense that it does 2 important things. One is it attaches itself not to the variable portion, but a fair amount of the conserved portion, meaning the virus could mutate, but it won't evade this particular antibody. The second thing that it does is the effector function. So when you get antibodies, once you get infected, you have antibodies against the virus. So if you were to get exposed to the virus again, your antibodies will react against it and neutralize it. The one thing that they don't do is they can't destroy viruses that are within infected cells. So at the free-floating virus particles, these antibodies can bind and neutralize them. But the cells that are already infected, these antibodies really can't do much about it. So you need them to have an effector function, which is what they do is they can recognize an infected cell and point to the T cells, hey, this is a pneumocyte with the virus particle in it, please come in and attack it. That's the effector function that you have to have. Now, the best of our knowledge, Regeneron and bamlanimab don't have that effective effector function. They primarily are neutralizing antibodies. This new one, based on the science that we now understand, actually goes after the stable portion and also has an effector function. And therefore, when you test it against many variants, it's very effective against all of them, including the Delta virus in India, as opposed to bamlanimab is already become resistant to many variants, are resistant to this particular monoclonal antibody. So much so in the United States, this has been withdrawn. We no longer use them. We're only using Regeneron and sotorvimab. The second problem also is once you reach this level of resistance, if you continue to give it, there's a high chance that the virus will actually mutate even more when you push them with monoclonal antibodies. And it's unclear what that mutation would do in terms of virulence and transmissibility. So we are at a stage now where the virus has now mutated and has developed immune escape mechanisms, and we're beginning to observe it in clinical practice. And then if you look at what has happened in India, this is data in India, where this is published out of, I think the ICMR collects this data, where they look at neutralizing and binding antibodies after an infection of COVID-19 in this year. So I'm assuming quite a bit of it is the Delta virus. They don't tell us in the study what virus variants that they collected in this. I'm assuming it's Delta virus. And they measured antibodies in people who recovered. And if you notice that the antibodies, or half of them, did not produce any neutralizing antibodies that are of use. So this group of people who didn't produce adequate amount of antibodies after they recovered from COVID-19 either are dependent on the effector cell T cells later on coming if they were to be infected again, or they're really not that well protected right now. And as you know, in terms of effector cell function, if you have antigen excess, you do not neutralize them well. You can't harness the T cells if you have too much antigen, or if you have too much antibodies either. So you need to have the optimal level of antigen-antibody ratio for the antibodies to not only neutralize, but also bind cells so that they can bring the T cells to attack it. So this is a problem that we're watching, where we're producing antibodies, which may not be so effective after all. And we've seen this now in the second wave in India, which we think is predominantly Delta infection. Somewhere between 10 to 20% in reports from India show that they already got infected last year in 2020. So the original strain infected, or the Italian strain, which was dominant in India at that time, infected people, and somewhere between 10 to 20 of them got reinfected with Delta, and some of them actually even got severe infection. So what happens in terms of vaccine escape and vaccine-related deaths in the United States? This is data from the CDC. In May, after 101 million people were vaccinated, by definition, to be included in this number, you have to receive both doses of the vaccine or the one dose of Janssen, and it's 2 weeks after the second dose if it's the mRNA vaccines, or 3 weeks after the Janssen vaccine is when the data is collected. After 101 million fully vaccinated people, we currently have 10,000 breakthrough infections. Still a very small number, but they very much exist. Majority of them, a slight majority of them, are female, 63%. This is a surprise because we think women actually produce more potent antibodies against vaccines than men, but for some reason there were more women who got these breakthrough infections than men. This is the United States. The median age was 58, and there was a range between 40 to 70. Out of those infections, 995 developed enough reasons to be hospitalized, but about a third of them were hospitalized for reasons other than COVID. So they would have been admitted for a medical reason. And since in the United States, everyone gets tested, they must have found them to be tested positive, but absolutely showed no symptoms of COVID whatsoever. There were 161 deaths in the United States of fully vaccinated people in May. More recently, in June, there were 0 deaths of unvaccinated. All the deaths in the United States in June were exclusively unvaccinated people. So at least by end of May, there were 161 deaths. The median age of them was 82 years old. So mostly the vaccine failed, leading to a severe infection in the elderly. There were no young people at all in this group. And of the 161 who died, 18% of them died for other reasons and had nothing to do with COVID. And 27% of patients who were fully vaccinated, nevertheless, tested positive, and they were essentially asymptomatic. So this kind of gives that credence that there are people who've been vaccinated who don't show any symptoms, but nevertheless are asymptomatically infected and can carry and infect other people. Now, why these 161 at all? I mean, why did these people have these breakthrough infections, and why more so in the elderly does it cause severe infection? So this is a study from Germany, Hamburg, where they used the Pfizer vaccine. And what they did was had 2 groups of people. One were healthcare workers, about 70, about 100 or so, and then elderly over the age of 70, group of 70 to 90 years of age, people who live in nursing homes. So they took that second group, vaccinated both the groups, and collected antibodies at 0 before the vaccine got given, and then collected neutralizing antibodies or anti-IgG against the receptor binding domain on week 3 after the second dose of vaccine, where they should have antibodies by then. And then later on at week 7, that's almost 2 months after the second dose of vaccine. And surprisingly, what they found was the young and the healthy produced antibodies as we thought they should within 2 weeks after the infection. However, the elderly took much longer before they developed adequate amount of antibodies. So this is probably perhaps the reason why would these elderly not produce enough antibodies. There could be many reasons. Some of them, maybe they have underlying medical conditions which may have compromised their immune system, or they may be taking many medications, and elderly often are on multiple medications that interfere with vaccine efficacy, perhaps. But whatever it is, there is delayed immunity, even though there's adequate immunity. So if they are exposed to the virus within this time period, they're likely to succumb to it. So when you use the definition of fully vaccinated, you may want to reconsider that definition to be slightly different in the elderly based on this particular study. We actually wrote about it. We wrote about 3 different cases where immune modulatory therapy, if somebody is getting rituximab or certain treatments for multiple sclerosis, that it actually reduces B cells enough that the vaccine will fail. We've also seen a patient who's gotten tetanus toxoid and the mRNA vaccine at the same time, had a delay exactly like this elder group here, who developed antibodies 8 weeks after the second dose of vaccine. What it's telling us, there are still variables out there we don't understand that may interfere with vaccine efficacy, which may be the reason why some people are getting vaccinated and still getting serious infection and dying. But that's still a very small number. By and large, the vaccine has been very effective in preventing severe infections. And I will show, moving forward, what else in the viral genomes that are changing that we need to worry about. Is the transmission into animal species. So there are many animals now that have been identified as being reservoirs, and these are the different variants of the virus, and you can see the variation in different portions of the spike protein. At least one of those variations has been shown to allow the virus to go into mink. In Denmark, we've seen it. The virus left the human host and went into minks, infected them, and stayed there until they came back again into the human cycle. Influenza does that. It goes into chicken and ducks and pigs and stays there, and the next season comes back again into a human cycle. So human reservoir, the animal reservoirs will be something of concern as we go forward if we were to ever end this pandemic, because this virus has the capability to move between humans to animals and back. And finally, coming to the human dynamics. And if you do have interest in epidemiology, you may want to consider reading this book on the rules of the contagion by Adam Picharski. And what he tries to explain, and I'll simplify it, is that the rules of contagion are the duration, opportunities, transmission, and susceptibilities. Each of them multiplied will give you the R of the reproduction. So if you look at it that way, and now trying to understand what is happening with our own, both in India and elsewhere, the duration of the infection, which means the longer the infection stays in an individual, there's more opportunities for it to spread. So immune suppression is well known. If you have an HIV infection, we know the virus sheds up to 21 days in them. Normally, a healthy individual who's not immune compromised, if the virus infects you, you tend to shed the virus at about 4 days prior to symptomatic infection, and about 7 to 10 days at the most, and you don't shed the virus beyond that. But if you do things like you suppress their immune system, because of other medications, or if they have HIV, they shed virus for much longer. So the longer the duration, more opportunities the virus to spread to another person. Likewise, the early use of steroids, which was done in parts of India, may have contributed to a longer period of viral shedding, because the steroid should have been only used in the second half of the illness when the cytokines are coming, and not from the time you're infected. That only increases viral replication and probably increases the chances of having spread. The opportunities to spread, the lockdowns and social distancing, I'll come to that in a minute. And then the host susceptibility. How much of infection mediated immunity is adequate? As I just showed in India in one study, it didn't seem to be that adequate. At least a portion of people who got infected then did not have adequate amount of neutralizing antibodies. And I also told you that if you had asymptomatic infections, you didn't really put up enough antibodies for you to have protection. Now, the problem, however, is there is a general belief that if you already got infected, why should you take vaccine? And that's something that I want to discuss a little bit more. And then finally, the T part of the DOTS is how do you prevent transmission, and the role of masks will come back again. So this is a very small report from Israel, just 6 patients. And what they did, they were all healthcare workers. And what they did was they had antibody titers of these individuals, both when they got infected, before they got vaccinated, and all after they got vaccinated. So these were healthcare workers who previously got infected with COVID-2, and then after recovery got vaccinated with Pfizer. And so you have, so this is the original, this panel shows the original virus. This is the B17 variant. This is the B3015 variant and the P1 variant. These are the neutralizing antibodies after infection. So each of these individuals had fairly adequate titers of the antibodies against the original virus, not so bad against the B17. But when you look at the B variant neutralizing antibodies, after the infection with this variant, they really did not have that much of antibodies after the infection. And just before they were vaccinated, they neutralizing antibodies even fewer than that. And likewise, for the P1 variant, they did not have adequate antibodies from the infection they got from this virus. And then they got vaccinated, and they got adequate antibodies against the original virus, enough antibodies against B17, B1351, and even the P1 variant. The point I'm trying to make is that the immunity that you get from an infection is inadequate. Number one, I think the problem there is the mutations, that the protein that you produce antibodies against has mutated and long gone, and you're dealing with a new protein. And secondly, I think vaccine-mediated antibodies does not have adequate amount of effector functions. They don't really stimulate memory cells as much as you would like to. Vaccines, on the other hand, actually do a much better job than natural infection. And I think this is an important thing that we have to bear in mind if we want to prevent the next wave. So, so I covered all that area. So we talked about the duration, we talked about the opportunities of infection and social distancing. I'll come to that. So my point I'm making is to decrease susceptibility, you have to increase immunity. And the only way around is to vaccinate and vaccinate and vaccinate. Vaccinate even people who've been infected, regardless of what variant they've been infected with. You still have to vaccinate if you want to contain it. In the United States, as Delta virus has begun to take hold, it has shown low rates of infections in states where well vaccinated, like New York State, and in states where the vaccine rates are very low, it's now the infections are rapidly increasing in numbers. So this is the value of vaccination, and we should not just be lulled into believing we are immune because of one infection. So this is a more recent study from the CDC about the masks and social distancing, which is a constant debate. So this is an experiment done where we now believe more than any time else that aerosol transmission is the most important way how the virus spreads. The fomites have a role, but I think we now very well convinced that aerosols are the most important way of how the virus spreads. And in this experiment, you have a participant here, a person sitting here, and a person sitting over here. This is 3 feet, this is 6 feet, and this is the speaker in a room. So just assume this is at a wedding that we often see people attending with and without masks, and you can expect this is what's happening. You can have a second way where the speaker is on this side, and now you have air ventilation system where this is the air that's coming in, and this is air that's going out. These are the vents outside, and they put HEPA filters, one in the front, in one model in the back, and one on the right and the left. Then they also raised them to see if they could get a better catch of it, and then ran the experiment to see how much of aerosols that you're seeing. So the participant A is this person, and it's colored as such, and this is participant B. And likewise, this group had universal masking, this group did not mask. And as you can see that if you use HEPA filters, you could reduce the rate from about 100 particles to about 30, you do, but look at the effect that masks do. But it gives us a few ideas that if you modify ventilator systems and use HEPA filters, if you have to end your lockdowns and have to meet in groups, and if they are unvaccinated, the best thing to do still is to mask up because that produces the best results. If not, then use judiciously using HEPA filters in the right position will reduce it to some level, but doesn't make the risk go away completely. So lockdowns are rough for any society and can be sustained for a long time. But if we can, on the other hand, use technology and some common sense and maybe continue to mask, especially people who are not vaccinated, we may be able to control the next level of spread again. And finally, before I end, I don't want us to forget that the third wave doesn't always come in viral infections. It comes in different forms. And one of those sad things that has happened in the United States, this is 12 to 18-year-old girls and 12 to 18-year-old boys. And this is the number of emergency room visits for suicide attempts. So compared to 2019, there's a 50% increase in suicide attempts in girls in the age of 12 and 18. So there are more of these social things that will be coming in to haunt us. So the third wave won't necessarily always have infections. It will have other implications that we need to prepare for, not just the virus. As Dr. Sudhakar mentioned, that there is also issue of post-COVID syndromes, and we'll discuss that at another time. So in summary, I think for us to mitigate a third wave, we need to vaccinate as much as we can. I do understand that in India, there's still a shortage of vaccine. But however, I think in the next 2 months, you should be getting more supplies. And then you will be faced with the problem of how to overcome vaccine hesitancy. And I hope the information that I shared with you can be spread and we can convince people to be vaccinated even if they got infected. We should continue to be vigorous with whatever therapeutic protocols we agreed on, like for instance, the use of steroids, limiting the dose so that you don't cause viral replication to increase. I think masks in India, where there's very low levels of vaccinations even now, should not be abandoned at this time. And I think social distancing is still something that we should advocate. And although lockdowns will end eventually, because economically they're non-viable, we still have to figure out a way how to use them prudently. At least the gatherings which are non-essential, if we can reduce them, I think we have some ways to go. So that's all I have, and then I'll take some questions.
Yeah. Thank you. Thank you very much, Sridhar, for that explicit presentation, and wonderful. I mean, we have a ray of hope that we can prevent it. Perhaps you follow the norms very rigorously, and I think it's a human behavior which ultimately dictates whether we are going to head for the third wave or not. And I have a few questions in the sense before I throw open to the others. One is, you were saying right in the beginning that there were about 40% of the people are getting affected with this Delta plus or the Delta variant. How do you think should we do this gene sequencing? Will it be done to everyone, or what is the criteria that are followed, and how vigorously the gene sequencing need to be done in context to the India?
Well, firstly, other than UK, no other country has done gene sequencing adequately. Even the United States, it's grossly inadequate. And so in New York right now, the gene typing, the criteria set for, again, there's only, the state lab has to do the gene sequencing, not every, although other hospitals have capability of doing it. But right now, the state a lab called Wadsworth Lab, which is a very well-known lab, does all the gene typing. The way we do it is that if a person is vaccinated and has completed the vaccine and nevertheless gets infected and has a very low cycle threshold on PCR testing, meaning that the person has a very high viral load, that person's genotype is done. And typically it's about 1,500 or so per month is the genotyping that they're doing in New York. Now, I can say we should do a lot more, but I think it's not economically possible. Even India, I think in the list of countries, India is not too far behind. It's UK is about 75,000 or so they did. After that, the United States did maybe about 10,000 or so tests. And then India has done several hundred. So India is not that far behind, even though the whole world is behind, if you can say. So I think it's easy for me to say do more, but I don't think it's practically possible to do it.
Yeah, thank you. Ram Mohan, you have a question. You raised your hand. Ram Mohan, please go ahead.
You muted, Ram.
The drug you mentioned, Sotrovimab, is new to me. What is the availability and cost? What's going on?
So it's now available in the United States for $1,000 per infusion. It will be priced the same way as Regeneron is priced in India. I think they released it in India too now. I think either GSK is in India too, so I think they'll be releasing it in India. It's available in the United States. It's $1,000 per dose.
And the other comment I wanted to make is that when you make the comment after data, the immunity that you get from the infection is inferior to the immunity you get from vaccine. That's going to be a very important public health education. I am now in Texas. For some reason, everybody stopped wearing masks 2 weeks ago, and only 15% are vaccinated. And the physicians are afraid to tell the public, don't come to my clinic if you're not vaccinated. Nobody is opening their mouth. So I'm working around people who are not immunized. And it's very, very
Yeah, I think Texas and Tennessee and the states which didn't vaccinate will pay a price for when Delta comes in. I think Missouri has already seen it. The governor of Missouri has said he needs help from the feds because the rates of infections, because their vaccination rate is less than 30%. And as soon as Delta came, it's now 50% of their infections, and the infections are raging already. I think not vaccinating people based on whatever their beliefs are is a very unwise thing to do.
And
Yeah.
my other comment is actually for Dr. Sudhakar. Everybody in Vizag says the problem with vaccine is lack of availability. I just want to reiterate the point. When it becomes available, will everybody take it? So the vaccine education still has to be prominent. Anyway, I'm just speaking from outside. Thank you.
So somebody typed, do you anticipate a situation where vaccines will be mandated? I think in many countries, once the vaccines are currently on EUA, emergency use authorization only, and that's the reason why governments are hesitating to mandate them. If they get full FDA approval, Pfizer has applied for full FDA approval because they think they have enough safety data to convince people that their vaccine is safe and should be taken. If they get full FDA approval, subsequently other national governments and their regulatory agencies, once that is offered full approval, then there would be countries which will mandate it. I think we can't get over this pandemic without mandating one vaccine or the other, because you can't have 50 and 60% vaccination rates and hope to end this pandemic. It's not going to end. Delta variant particularly is sitting and watching. Each time you have a big wave of infections, they automatically after that, you will see all of it disappear as it's happening in Visakhapatnam. You can see it. This happened again and again in every part of the world. You can see now in Visakhapatnam, the virus is gone. Infections drop and drop and drop because there's immunity developing as they get infected. But it's very transient. And then it goes away, and then you get another 2 months later, another bout of infections. So we need to break that cycle, and the only way to do it right now is with vaccines. Dr. Budraju, yeah.
Yeah, so I wanted some comments from Dr. Chilumuri. I've been hearing some data about incubation in immunosuppressed hosts. There was, I think, a publication in Lancet not too long ago that they've seen the virus hanging out in these immunosuppressed individuals for as long as several months. And in the process, they've actually seen all these variants mutating in this set of population. In fact, in addition to vaccine hesitancy and lack of speed of vaccination, next wave, if it happens, they suspect it's going to be generated from this subset of immunosuppressed or immunocompromised hosts where new mutants and emerge with vaccine and immunity escape mechanisms. So I wanted you to comment on that article.
Yeah, absolutely. Actually, if you recall the NEJM, the first article, this is way back when there was a patient with lupus anticoagulant. I think the NIH actually managed this patient. And he had a flare-up of, he had a cardiolipin crisis, so it was clotting everywhere. And they were treating him with high doses of steroids. And that's when he got infected with COVID. So they couldn't take off the high dose of steroids in him. So because of his anticardiolipin antibodies. While they were watching, there were mutants developing and they were panicking what will happen next. At that individual, they could see the virus they actually genotyped the virus and it completely changed in that single individual. Likewise, when bamlanimab was given alone in the clinical trial, the BLAZE trial, they were escape mutants developing because it was a single antibody against it. which was not adequate at all. The moment you didn't have adequate neutralization, the virus mutated rapidly, but it was very transient and disappeared. So I'm not surprised that immunocompromised individuals like organ transplants, if they get infected, not only will persist longer, but actually will mutate. And so far, none of those mutants have showed up in the general circulation, but it's only a matter of time. So that's why I give monoclonal antibodies to them, but I'm very concerned now that what I'm doing any good or harm. I mean, they may get better, but are they pushing the virus to mutate and spread later on? So that's a concern I think we need to understand more.
So the other question, so the other question I had was, so I heard Anthony Fauci commenting the other day about the strategies for the third dose or booster dose. And the data that he seems to be indicating is looking for a rise in vaccine escape numbers. And that would be the time to probably start looking at doing boosters. Has there been any data as to how they came up with that strategy? Or
so the first thing is there is no vaccine escape that significantly, and the reason has been that inadvertently or maybe purposefully, when they selected the mRNA, it had nearly 75% of it is the spike protein that sticks up, as I told you, the highly antigenic portion, but it also had the conserved portion of the protein, which actually not only produces antibodies and be future protected against variants, but also has a better effector function than just the plasma, for instance. So I think that's the reason why the vaccines remained efficacious. We're still not so worried that there's escape from them. Almost all the infections that we get are very mild. We've seen 26 of those patients in our own hospital. They're very mild. You don't even have to admit them. So I think at this point, 11 months, and now we have 10 months of data. I think the vaccines are doing what they need to do so far, but we'll wait and see what Delta will do, because I think it just came into this country, and that would be something to think about. Yeah, Dr. Prem.
Yeah. Actually, my internet is quite unstable. I switched off the video. And at the outset, I would like to tell you that we are happy to announce that there are 2 gene sequences came to, one to Tirupati and then one to Isaac. They will be commissioned soon. So we'll be doing more gene sequencing. Actually, I have a comment to make on this. The ICMR has said in a recent article that the waning immunity of the individuals or the viral evolution, that means, immune escape, may not drive the third wave automatically. But if there is a viral infection with a high transmissibility to the tune of R0 4.5, then it could be switching the onset of third wave. That is one observation what they did. But that is quite unlikely that R0 of 4.5 has such a high transmissibility virus. But in the given circumstances, how the people are behaving, the COVID appropriate behavior again is not seen. So automatically the infections will be more among the people. So transmission will be more number of infections, more transmission, more viral infection, viral replication, leading to more mutations. If such mutants arise, automatically at one point of time, a viral mutant with a high transmissibility might arise to trigger the third wave. That is one. The complex human behavior we observe in everywhere here in India, in particular in Vizag, I see. The helmet will be hanging at the back seat of the motorcycle. and mask will be hanging down onto the neck, and the police will be penalizing those people who are not wearing seat belts. There are t-shirts designed where there is a belt mimicking, print on the t-shirt to, give a false impression to the police that they are wearing the belts. So they never realize that it is for their safety. They try to evade, just like, immune escape from the virus. These people try to escape from the people, but they never try to escape from the virus by adhering to the COVID appropriate behavior. That's what I have seen. And finally, Sridhar, I have one question. Earlier, the belief is in children, the ACE2 receptors are less in number. They are not so developed. So low affinity viruses may not affecting the children so in large numbers. But as far as this delta or delta plus, that is AY1 clade,
Yeah.
where, as you said, the spike protein one part is sticking it out. And they say even if there are less number of receptors in the children, the sticked out spike protein might adhere to the receptor, as well
Yeah.
as tight binding of the receptor might drive a huge number of cases in children. What is your opinion about it?
Actually, that is correct. The Delta virus unique aspect is that it has a higher affinity. Each time the spike protein changes, it is gaining in function actually. So usually when you have mutations, some of those mutations actually make the virus less efficient in attaching itself to human cells. But so far, most of the variants that are growing in numbers are ones where it actually gained in function. It's even better capable of attaching itself to the ACE2, and Delta virus is probably the best of them. The second thing is even the change that Delta virus has acquired, it's still only about 40 to 50% efficient. It still will gain even more. I think the goal for the virus to reach 80% efficiency so that it can spread quite easily. So at a substantially higher functionality than the original Wuhan virus, it's now able to attach itself to pretty much everyone, including children and young adults. So this is to be expected, and I think as the virus is under pressure to mutate, as you just saw in India, huge number of people got infected, and the viral numbers has dropped. So it's time for it to mutate now. So there's a group in Washington University in St. Louis who studies mutations in spike protein. And they developed actually a model where they can predict 4 months from now that which next mutation is about to spread. And I think the studies like that are very useful for us to understand more where's the next big variant going to come. And I think if Andhra Pradesh is going to have 2 genomic sites, that is amazing. But you will be able to see using that kind of studies, where's the next mutant coming and will it be highly transmitted? That information is crucial to have.
Yeah. Thank you. Yeah. Sridhar, just to give an update of what Rammohan has raised, and over a period of time when we have seen right from the beginning, from 16th of January, when we have started the vaccination, you could see that there was a hesitancy in the beginning. Later, people started realizing the importance of vaccination and the advantages of that by looking at the people who are not getting severe infections because of vaccination. So the urge for getting vaccinated has become increased, though the government is not able to supply the adequate quantities. So Naveen has posted something there saying that it is not the hesitancy, it is the vaccine urgency which is more important.
Yeah.
And surprisingly, you all must might remember that we had a session on AEFI also. Then we have presented some 9 cases at that point of time. Yeah, but now surprisingly, we don't get any of those these days because most of them, as we have seen, out of the 11 cases, 9 of them were anxiety neurosis. People
Yeah.
started realizing that it is quite common to get a headache or a fever or something of that sort. So these days we don't see such cases. That means the public education has worked out quite a bit.
Yeah.
And now
Yeah.
the need of now the need of the hour is to supply the vaccines. To me, it always appears that it has to be opened up, whatever little that is available, instead of sticking to the timeline, to the age factors, like above 45 and all. Somehow, I'm not too happy with these strategies. What is your take on that? Above 645, you try to vaccinate them for some reason, and if you don't, if they don't get vaccinated, and you try to push them to get vaccinated through various means, and at the same time you are denying a person who wants to come forward and get vaccinated. That really do not sound very logical to me. What do you think about that?
So when I think when public health officials decide one group to get over another group, it's not really based on science. So what you're targeting is if you're going to give young, healthy people vaccine, then you're trying to reduce the spread. And on the other hand, if you decide to give older people the vaccine, then you're trying to reduce the deaths. So that's the two choices public health officials do. If you are under pressure to reduce deaths, then you will give the vaccine, the limited vaccine that you have, to people who are more likely to die, which will be people over the age of 55 and above. But if you have adequate doses of vaccine, then you would vaccinate everyone. But I think each country's problems are unique. In India, they started the same strategy as the US, give it to the older people. But in India, the spread is primarily through young people, and they're spreading it, continue to spread. I think that this huge wave was more likely caused by young people than that much of older people. So at this point, I think whoever wants to get it, if it's available, give it. Should be the strategy rather than having any restrictions. The second public health rule that India made is that if you got infected, you can wait some months before you take a vaccine. That kind of sends dual messages. That it kind of sends that you probably don't need the vaccine once you got infected. And it also assumes that everybody got infected is actually completely immune to it. So it isn't, both are false. In fact, you do want to get vaccinated, even if you got infected, as early as you can. Again, availability of vaccine is a problem, I understand. But I think by September, India would have, based on the current projections, a lot more vaccine than they have now in July. So hopefully India will open up and vaccinate everyone. That's, I hope, will happen. Somebody about the third vaccine, is the question whether to give a third shot for immune compromised? Is that the question? There's one study now in organ transplants just published showing that if this, after giving first and second doses, it didn't produce enough antibodies, so they gave a third dose of vaccine and produced substantially more antibodies. So I think in small group of people like that who are immune suppressed, you may gain with a third dose of vaccine. Whether that study was not mix and match, it's the same vaccine given to 3 doses. There's now a mix and match study, which seemed to also be reasonable to try, but that didn't have 3 doses. It still only had 2 doses so far.
Yeah, I think Dr. Buddharaju has a question. Dr. Buddharaju, please go ahead.
Yeah, so to answer Dr. Sudhakar's question, what I've been observing is there's 2 issues going on with the vaccine situation in India right now. One is availability of adequate number of vaccines. Number 2 is cost, and number 3 is access. So predominantly the rural population in Andhra, at least, probably the entire country of India, rural India is dependent on government services in terms of getting access to the vaccination. So the government itself might not be getting enough for, doses of vaccines from Delhi. That's one issue. Number two is some of the other vaccine producers have opened it up to the private sector, especially in towns, in cities. So I see people are figuring out how to get access. Even 18-year-olds and 19-year-olds, I've seen them getting vaccinated in big towns through the private sector. So there's some access issues there. And I'm also noticing that now through the vaccine issue program, they're asking people to come back for second dose at 3 months, is what I'm hearing now. So I think the strategy of ICMR seems to be, let's get the first shot in as many people as possible. Let's achieve some degree of immunity in the country. We might not get 80% efficacy, but with the first shot, at least we can hope for 40 to 50% efficacy, and thereby reducing the spread in the immediate future, and hoping that 3 months from now, the vaccine availability will be much higher. And I think that's probably not a bad strategy in terms of, instead of, giving smaller number of people 2 shots, giving a larger population 1 shot to achieve, 40% or 50% efficacy. That might be the strategy. I'm not sure. I'm just guessing, but that's where we are right now. But I'm hearing that come September, October, they'll have a lot more availability, and people will start getting their second shots, and the immunity levels will be climbing up slowly.
Yeah, that's the strategy they used in UK. I would say it's a strategy with mixed results. UK had quite a severe second wave, and they had given a fair number of people 1 dose. I think you have to do with what you have. This is the dose you have. That's the best you can do. And there's no other way to solve that problem. If you get more vaccines, give it to more people. I think India will have, I see all of you saying that there's no hesitancy in India. That's because you created a scarcity now. Everybody wants the one that nobody has. But once it's widely available, there will be tremendous hesitancy. In India, in the United States, vaccines are widely available, yet only 50%. If you take the whole of United States, it's only fully vaccinated, and the vaccine is free. There's no charge. You can go any place and get it. It's only 47% today. And that's the way human beings are. So I don't think it'll be any different in India too. Let's talk in October, and you're telling me all Indians are getting vaccinated unless it's mandated. That's not the India I know of.
Yeah. Prem, please go ahead.
Yeah, thank you, sir. Dr. Sridhar, here I may sound somewhat unscientific, but it's a little personal or selfish, whatever. Myself and Dr. Sudhakar, we took the AstraZeneca vaccine in the month of Jan. I remember Jan 16. And the second dose 4 weeks later. Later, we came to know that if the second dose is given 8 to 12 weeks after, the more robust immune response would come. But now, already 7 months past our vaccination, and Cipla is authorized to sell Moderna vaccine. Do you advise us to take the third shot, Moderna, thinking that the second dose taken too early?
So let me answer the first part first. So the people who got it in the right time, they are nowhere inferior. I think what part that they didn't measure is what happens to them 6 or 8 months after the vaccine. Then it evens out. There's no difference in people who got it the second dose 1 month as they should, the original schedule, which is how I got it. Because what they found was the germ cells centers were continuing to produce antibodies as needed. So it persists for months after you got your vaccine. So whether you got your second dose 3 months later or 1 month later, you actually watch them 6 to 8 months later, you actually will find there's no difference at all. So that's so first I want you to be aware of that. So you're not really compromised yourself because you got the dose of second dose in 4 weeks. Now, we have given people who received vaccines in other parts of the world, whether it's Covaxin or Sinovac or AstraZeneca, and they come to United States. We are allowed to offer them, and we've given it. So would I take it? I would. I would definitely take a mRNA vaccine, even if you had an AstraZeneca. Why? One, it hasn't harmed anyone by giving that second dose, third dose, I mean, in your case. We've given it for people who got other vaccines in their respective countries in the United States, and all we saw was that they put up nice antibodies, didn't have any adverse events. They do get a little bit more body aches, which is, of course, that's variable. Some have it, some don't. So if you have Moderna, I would at least take 1 dose for sure.
Do you advise 1 dose or all in total 2 doses, Moderna?
So in the US,
after COVID.
in the US, we give both doses. That's what we do. So if you received, for instance, Covaxin,
after the previous complete vaccination by Covishield, we
gave complete mRNA doses, both doses, and they were fine. Because we don't, in the US, we will only accept the FDA approved vaccines as vaccines right now. Although we are allowed to use the WHO approved vaccines, but we have an option to offer the patient an mRNA vaccine if he only got a FDA unapproved vaccine like Covaxin, Sinovac, or Sinopharm, or for that matter, Sputnik. We are allowed to offer them mRNA vaccine. Although the WHO approved vaccines are thought to be adequate as far as CDC is concerned, they say if somebody got AstraZeneca, you don't really have to offer them mRNAs. And the CDC agrees with that. But we are allowed to offer. And we offer, and many people took it, and it didn't seem to harm them in any way.
I mean, how soon?
Thank you so much.
How soon? Like 6 months, do you think after the second dose would be adequate to take the third dose? I mean, the different vaccine.
I mean, once you commit yourself to mRNA vaccine, you should stick to the schedule. So if you take one, the second dose is 4 weeks later.
Yeah, I mean, from now onwards, like we have taken on 16th of January and maybe in the first week of March. Now, would September be all right for us?
Yeah, I think in September you take 1 dose and October the second dose. Should be all right. We don't see any problems so far with it.
Yeah, right. Ramohan, Ramohan, you raised your hand.
Yeah, I was disturbed by the slide that Sridhar put up about female teen suicide rate in India.
That's not India, that's United States. That's United States.
Okay, sorry. But in India, I had been watching that rate for the last 5 years. It has gone from 8,500 to 9,000 to 9,500 to 10,500 as of this past year. Now, this was going up even before COVID. I thought you were implying, because of what's going on in the country, so many adults dying, the dislocation that has happened with closed schools and not being able to go out and party, etc., it may have increased the suicide rate in America. Same thing could happen in India too. However, all the Indian people always talk about how important their children's health and wealth for them is. So Dr. Sudhakar, maybe you could use this to put some fear in the people about whether it's mask, social distancing, or vaccine. Look, your children are at risk, for heaven's sake, pay attention. I think that behavior change has not occurred enough, sir, after 4 million deaths. Amazing. So,
I mean, in India, there are many children being orphaned by the virus. So I would not expect any less. I think the suicide rates and depression rates will be substantially higher in India too. Indian kids are no different than American kids. Stress is stress everywhere.
So in the public health education campaign, pro-vaccination, this might be an element to use. Do not put your children at risk. Take the damn vaccine.
Absolutely.
Yeah. Point well taken, Ramohan. And I think there's somebody else as well.
Buddharaj is.
Yeah, so I
yeah.
just wanted to comment on that suicide rates. In fact, the government of Andhra Pradesh and probably even government of India has taken note of the mental health aspect of the pandemic, and Andhra now actually has a helpline or hotline for mental health. I think it was started last week, and most states in India are now paying attention to mental health. And there's significant impact on the mental health. That's already been noticed in India.
Yeah, it is 104 Manonibram. That is the project floated last week.
I think it's a very good thing to do. And it's not just young kids. I think young adults also, and all of us. I think one of the problems
for everyone, sir. It is.
Yeah. Healthcare workers in the United States, surveys across show 20% of the healthcare workers experiencing burnout after the pandemic. Many are leaving, taking early retirement. So the impact is not just on the general public. The healthcare workforce takes a huge beating too.
Yeah, for every age group, for everyone, the the facility is available. It is 104 telepsychiatry. The name given by the government is 104 Manonibram. That's
okay.
Sridhar, if you don't mind, I had not been watching the number of infections in vaccinated people. You said it was something close to 11,000 with 161 deaths.
Yeah.
If many of them died of comorbidities, elderly, etc., it would contaminate. In your own assessment, how many are attributable to vaccinated individuals who died of COVID, where you could say that it was not from previous awful heart disease almost ready to kill the guy?
Very, very few. In
Very
fact, we haven't seen it in our own experience. We have not seen any. Even in the 161, most of them are elderly who had multiple medical problems. I think it's difficult to prove that COVID actually caused it. One of the problems in defining death is if an 82-year-old who's vaccinated comes in with an acute stroke, he probably has an acute stroke and died from it. Unfortunately, because COVID is a hypercoagulable state, sometimes you can't say, well, COVID didn't do it. So therefore, it still stays in the mix. That's the problem. Otherwise, we haven't really seen people die after being fully vaccinated. We haven't seen it all.
So the CDC MMWR does not have much of a breakdown. For example, is there any single 40-year-old, a 50-year-old, a 55-year-old, or mostly elderly?
They're mostly elderly. They're mostly about 70 years of age. Yeah, there are not many. In that cohort, there are no young people who fully vaccinated who died. Actually, in June, they found none at all. There's 0 deaths in the United States in vaccinated individuals. And the entire cause of death in the US with COVID currently is only unvaccinated. That is the CDC's current standard, current data.
I think there's one more question in the chat box. Naveen says that Covaxin phase 3 trials released yesterday say 94% efficacy against death.
Yeah.
Yeah.
Which is very good data to have, because I think this gives you a lot of confidence in the vaccine. For two reasons. This is one of those vaccines which is actually done. The trials were done when the variants were very much in the mix. As opposed to Sinovac and Sinopharm that China did, was done when there were no variants and the vaccine looked like it's efficacious. But once the variants came in, the Chinese vaccines uniformly failed. They are not effective. They have 50% efficacy right now. So one of the advantages of developing the vaccine a little later, maybe it actually covers the variants slightly better.
Yeah. And Sridhar, next week we're going to have Dr. Paul Kelly.
Yeah.
Okay. Thank you very much for arranging him to come next week. Because I think now, these days we have to concentrate a lot on variants and
yeah, he's going to talk about the viral biology of variants. Yeah.
Yeah, that's wonderful. Because at this time of reducing cases, it's always better to impart this knowledge of about variants. Because in the thick of the second wave, we spoke a lot about the treatment. Similarly, now it is variants which need to be concentrated. And perhaps one more session on the post-COVID sequelae also, individualizing. And I asked Ram Mohan to speak about the neurological aspects of the post-COVID sequelae. I think he'll be taking up after a couple of weeks.
I think there's a question on NSAIDs after vaccine. I think this was concern from other vaccines. There's no evidence that NSAIDs interfere with mRNA vaccines for sure. But if somebody can get away not taking NSAIDs, I would certainly not take it and give vaccine without any medications that are unnecessary. Then I wouldn't give it. But if the person absolutely requires NSAIDs that you cannot stop, then you can continue with them.
Yeah. So with that, I think we have had a discussion of almost 1.5 hours. Thank you very much, Sridhar, for the wonderful presentation and the interaction. I think today you have not only covered the entire gamut of how to prevent the third wave, but also answered so many questions, individualistic as well, as to when to take the third dose. That's very, very important for all of us here. Thank you once again, and also thanks for bringing in Dr. Kelly, who is going to come next week.
Yeah.
And thank you, Ram Mohan, Buddharaju, and Dr. Prem for interacting. Thank you all. And with that, we'll end this session. Bye-bye.
Okay, thank you. Good night.